Hey everybody, I'm your four-eyed professor, Chris Levens, and I'm super excited to talk to you today. Our roll call is for new and experienced ODs, optometry students, and even those just interested in this profession. We'll cover a number of topics together, and I'll help you see them through a professor's eyes. Please take your seats. School's in session. Welcome back to the Four-Eyed Professor podcast. This is a special episode in that this is an Opto Cribs Four-Eyed Professor podcast. I'm Chris Levens. Thanks again for joining. And as often I say, we have a new topic, a new guest, is something that we've not talked about before. And so I am going to welcome to the stage Dr. Randy Charrier. Randy, thanks for joining us today.
Thanks for having me. It's great to be here.
So before we dive into the content, which I haven't even alluded to what we're talking about, but we are going to talk about the idea of scleral lens fits. We're going to talk about how you may use Heidelberg's ANTERION technology to make this a less cumbersome task. The advent of scleral lens fitting in eye care has, well, if I say taken off, that's like one of the biggest understatements I could say in the last decade plus. But it's enabled us to take care of patients which we really couldn't effectively take care of before, where they see well and they see comfortably, and that's kind of blows me away from that perspective, given that I never would have predicted that scleral lenses would reinvent themselves after decades. But before we dive in, and we are going to have an opportunity to see your practice live. And I just want you to introduce yourself to the audience and tell us some things about you, the optometrist and specialist in scleral lens fitting.
Sure. So my name is Randy Charrier, and I have been running specialty contact lens practices my entire career. I started out in the Navy working for the Naval Medical Center in San Diego, which at the time was the largest hospital in the Department of Defense. So a lot of war injuries. There's a ton of keratoconus in the military. We were a teaching hospital, so there were multiple specialists there. A lot of infant aphakia, and that's where I first got into scleral lens practice. Really, it was the only choice. Scleral lenses weren't really that big back then. There were very few to choose from, and limited parameters, limited knowledge on exactly how we should even be fitting them. But they were really the only lenses that would work for some of these horrendous injuries that we would deal with, and some of these really awful cornea transplant complications. So I did that for about 4 years, and I left the Navy to purchase an existing specialty lens practice in Houston, Texas. Mm-hmm. That practice had about 1,000 keratoconus patients at the time. We've since grown it to over 3,000, in addition to a lot of other specialty type fits for various anterior segment disease. I stayed in that office for about 10 years and decided I wanted to be closer to home. Problem was that home was 40 miles north of Houston. Right. But one of the benefits of a specialty lens practice is that your patients tend to come from all over. So I was able to move my practice 40 miles north of Houston. Wow. We retained the majority of our patients, never really noticed anyone dropping off. But that's just a testament to what these lenses can offer people. We've been here now, I think, about 4 years. We're about to start our 4th year in this new location, and everything's going great.
Awesome. Well, as always in these conversations, somebody says something and that just sparks more interest and more questions on my end. But my experience in the military paralleled yours. I was in the Air Force in Washington, D.C. at Malcolm Grove Medical Center, where we shared patients with Bethesda and Walter Reed as well. And even in the mid to late 90s, the volume of keratoconus was astounding to me. And it really took me by surprise.
It is shocking.
But in those days, we did not have the technology that we're talking about today. And so we struggled with little button, RGPs and piggyback lenses. And you may improve vision, but comfort was horrific. And so these people
Right.
were really struggling. And so it's been a remarkable advent. But the other thing that you touched on is the first time anybody has ever told me on this podcast that they picked up and moved their practice. I mean, I have to think that you talk to some patients and say, hey, if I do this, is that okay? Obviously, you mentioned you looked at the geography of care in this field. In fact, maybe you were the only player, and so that would help. But it had to be scary.
I'd like to say that were the case, but honestly, I'm a person who, once I decide something's a priority for me, I follow through with it regardless. And I actually anticipated losing about 40% of my patient base.
Okay.
And once I became okay with that, then that's when I made the decision to move. It was shocking to me that I didn't lose that many patients. I mean, my schedule was booked out 2 weeks from day one of being here. And so, I think early on in my career, I really thought that the success that I would have in clinic would really depend upon my personal skills at fitting.
Right.
Over the years, I've learned that is unequivocally untrue. I mean, it's the skill is important, yes, but really what makes patients seek you out and come back are when you have set up systems that allow for consistent good outcomes. And it's those systems that they're willing to travel for. If they know that year after year they've been getting a certain result, that's worth driving 45 minutes.
Oh, yeah, easy.
Yeah. So, but it was a shock to me that we didn't lose more patients than we did.
So just some perspective about the Houston Metroplex. So if you were living 40 miles away from where your initial practice was that a 40-minute commute, or was that something more than that?
Totally depends on the time of day. When I would commute to the office in Houston, when it was in Houston, if I left before 6 a.m., it would be about a 45-minute drive.
Okay.
If I left after 6 a.m., it could be an hour and a half drive. I mean, it's highly variable.
Yeah, I recall that from, living in any mega city. You have one issue or just the time of day, and now your transit can double,
Absolutely.
if not more. So as we talk about scleral lenses, and so we're already talking about not just a complex lens, but we're talking about a complicated ocular surface. And now, because of where this lens is fitting, we have to be cognizant of the corneal curvature as well as the conj and scleral curvature as well. And these are not normal eyes usually. And so one of the barriers that I hear from people who are in a practice that has a need for this, but maybe scares them a little bit away, is chair time. And am I going to have to go through multiple refits for just every single patient I do here? And so when you're approaching a brand new patient who you've not worked on their ocular surface and with a scleral lens before, how do you get started?
So I think the process really should start with first contact. When a patient calls my office, sometimes they're referred from, well, most of the time they're referred from other doctors, but if that's the case, we reach out to them. But when we make that first contact, I have dedicated staff members who are trained on explaining to the patient the process, explaining the potential costs, explaining that, trying to get their mindset. We're not just screening eyes during these phone calls, we're screening their mindset. And, we want to know what's bringing them here now. What failures have they had in the past? What are their expectations? Are they looking for perfection, or are they looking for improvement? Getting an idea of that helps me when I get into the exam room with the patient, streamline what I do there. And so the first contact is extremely important. And it also kind of lets the patient get accustomed to what we teach here, which is you're not coming to have a contact lens fit. you're coming to have your ocular disease treated. And just as if I were treating uveitis with a steroid,
Right.
I'm treating keratoconus with a specialty lens. There's no difference. A steroid isn't going to make vision better in keratoconus. A scleral lens will. And so that's the appropriate treatment for that disease. And so we kind of try to shift their mindset into something maybe they're not used to.
So how do you tackle then a patient whose immediate communication with you is they want perfection?
We still schedule them. We don't turn anyone away. But when they get to the exam room, knowing that from the intake, from the first contact, knowing that about the patient, I'm able to go in and use my time more efficiently, because I know I'm going to have to explain to the patient. I'm going to have to gauge if they're understanding what I'm saying or not. And I've got tons of analogies I use, like a Tylenol doesn't always cure a headache. A scleral lens may not always cure all of your eye problems, but I get to kind of frame my examination at that first visit based on what I've already learned from their interaction with the staff. And to me, that saves a lot of time, because if after I feel I've done my best to explain that, I have no problem telling the patient, look, I think this is going to be a failure. I think what you want is something this can't really give you.
Right.
For a good example of that would be like an RK patient who wants no more glare at night.
Right.
That I can't. I'm not a magician. That can't
Yeah.
happen. And so, I have no problems just being upfront with the patient and telling them exactly what I cannot do. And if anything, I oversell that. I will
Yeah.
tell them that I can't do things that I think that I can do sometimes.
Sure.
Because in a patient like that, you've won, when you actually make it better than they think you can make it.
So you want to under promise and over deliver.
Exactly.
Yeah. So, pick a hypothetical patient that is your lowest hanging fruit. Maybe it's a slightly irregular cornea. Maybe it's a early in the disease state X, and you believe this one is not going to be challenging. And as it turns out, it's not. Just what you thought was going to happen happened. What is your expectation on time spent to have success? And then when are the interventions, interactions, follow up thereafter, so we can get an idea of what type of chair time and refit time we're actually talking about?
Yeah, it's so variable. Your chair time depends on so many things. It's probably mostly influenced by the patient's personality, really.
Mm-hmm.
But insurance plays a role.
Sure.
Do I have to, do things to prove that the patient qualifies for their vision plan benefits, for example, and that's brutal. I just had a patient on Friday who had a penetrating injury, also had keratoconus, enormous central corneal scar, and then a bit of scarring on the other eye as well. The patient had a vision plan that required me to prove that the patient could get 2 lines better acuity on the eye chart with contacts compared to glasses, which was obvious just by looking at
Yeah,
them that
absolutely.
could be the case. But in a case like that, you have to spend the time doing refraction on these patients, and how much time you spend on that, of course, is up to the doctor. But if I'm going to do it, I'm going to do the best I can at it. So that kind of eats into the time a little bit, just as a requirement that I normally wouldn't do on a patient. If there are patients that you can, after you have a bit of experience with them, you can tell that this is not a glasses wearer. This is not they're not gonna get functional vision with glasses. And so wasting your time on that, is futile. But in those cases, you have to. There are also patients with comorbidities. You have oftentimes what I found dealing with anterior segment disease my entire career is that with anterior segment disease often comes posterior segment disease.
Right.
And and then you have the typical age-related things, cataracts to deal with as well. Making sure that you're dealing with all of those things, taking care of the patient is front and foremost, and I think that's why I don't view myself as just a contact lens fitter. These patients have eye problems, they have eye diseases, and we're the doctors who help them with those eye diseases within our scope. And so it can really be variable on the chair time as far as how much time it takes. But I will tell you what I have found that streamlines what we do very well. Almost the first thing I do, well, the first thing I do when I sit the patient down is I'll introduce myself. I'll take a quick look at their anterior segment. Immediately after that, I get a potential acuity measurement. That is incredibly valuable.
Sure.
The potential acuity measurement not only lets me know what's possible, but it also lets the patient see what's possible.
Mm-hmm.
And so the way I do a potential acuity measurement on an irregular cornea is I'll select a rigid lens. Sometimes it's a corneal RGP, sometimes it's a scleral lens. I'll place that on the eye and I'll do a spherical over refraction, and then I'll pinhole. If I get improvement with the pinhole, then I'll do a cylinder over refraction, and then I'll pinhole again. And that is the acuity that I would expect to get at the end of the fitting.
Got it.
And so that really guides the rest of the conversation. I will let the patient know, okay, well, this, I understand that you wanted to be able to, read the street signs, but, you have a lamellar hole in your macula,
right?
And when I correct everything I can with the lens, you're still not going to be able to read those street signs. Do you want to proceed? And it's incredibly valuable. You might think that, well, if you can't really meet the expectations they had, then you're going to lose the patient. I don't find that to be the case. Patients may come in with the expectation of perfection, but in the hands of a clinician who can explain to them what's possible and what's not possible, their mind shifts and they can start to then accept, well, this is better than what I've got. And so they're willing to go through the cost, through the process, through the inconveniences of the follow-ups and the rigor of the learning, application, and removal. It becomes worth it.
So before we take a walk through your practice, one of the things that we're going to be talking about that I alluded to before is your utilization of Heidelberg's ANTERION technology. I've used that technology in research, but because I'm not for example, scleral lens fitter, I have not used it in a ton of direct patient care. What sparked your interest initially about that technology?
So I think technology is wonderful. I don't trust it completely. I think that, especially when you're dealing with OCT imaging of any type, spectral domain or swept source, the instrument makes some assumptions that may not be, correct. For example, the previous spectral domain OCT that I used to use was very high-end OCT. That instrument assumed that the first contact was the cornea. The simple fact is scleral lenses have a different index of refraction than the cornea does. And so if the instrument's assuming that it's the same index of refraction of the cornea, then the measurements posterior to that are going to be slightly off.
Sure.
And so, I never trust equipment 100%, but I do consistently, at a fault to me financially, upgrade to the most advanced equipment as it comes out.
Mm-hmm.
I do think that I need all the help I can get.
Yep.
And that's my justification. The ANTERION is, in my practice, there have been very few instruments that I would call game changers.
Mm-hmm.
When I brought in specular microscopy, I felt that was a game changer. When I first got my first OCT, I thought that was a game changer. ANTERION is by far the biggest game changer I've seen. And
wow.
What makes it special to me is that I can assess the fit at the slit lamp, and I can be pretty accurate for the most part, but I can't always necessarily remember what that one area looked like, or, was there compression and I just missed it, if there's compression at the follow-up. What the Anterion does, it works on apps basically,
Right.
and the app that I'm talking about when it comes to imaging is called the imaging app, and this uses swept source OCT, which has a much longer wavelength than spectral domain, and so it's able to penetrate deeper. I find that it's actually able to penetrate better through opacities, but you can get all the way down to the posterior lens capsule with this thing. So you can even see if, the vision doesn't make sense. Maybe there's something lenticular that's
Sure.
at play. But what's impressive about this is that in one scan, you get 5 raster pattern, like a radial raster pattern, where you can see the entire fit 360 degrees. The scan goes out to 16.5 millimeters. So if you're fitting a 16.5 millimeter lens, you're
Right.
seeing the entire fit of the lens. And it's been eye-opening to me on some of the things that I've missed because of that, especially things superior or superior-nasal, things that I just didn't really have my focus just right at the slit lamp for on those areas. And in defense, it's hard to focus on those areas when if you're fitting a lens with a really high sagittal depth, a really steep base curve, it is very difficult to focus on those areas unless you have the patient look off to the side, and then who knows how that affects the fitting relationship when they're looking at a primary gaze. But the Anterion allows the imaging in all those areas with one scan without the patient having to look around.
Right.
To me, that alone is worth the cost of the instrument. In addition to that, though, you have the Cornea app, which is not just a topographer, it's also a tomographer. It gives you wavefront data. It gives you epithelial thickness maps data, which there's research now in dry eye disease and the usefulness of the epithelial thickness maps. And there's definitely, I've used it for diagnosing keratoconus. We know that the epithelial thickness responds to changes in the stroma. And so if everything's, subtle, but there you see some stromal thinning, and right at that stromal thinning area, there's epithelial thickening, that's just further proof that it may be keratoconus or some ectasia happening. You get stromal thickness maps. So it's really all inclusive. It's everything that you could want from any instrument, aside from maybe it being a profilometer to directly be able to design scleral lenses.
Sure.
The cataract app provides biometry, which is important because sometimes when we're fitting patients, a patient may come in with a 50 diopter cornea, but yet when you put the lens on and you're over refracting them, they're over refracting minus 19. Well, that doesn't really make sense. And so a quick look at the cataract app shows, oh, wow, yeah, the axial length is incredibly long. There must be a posterior staphyloma back there, even though I can't really see it because the cornea is, not clear enough for me to see that through a BIO examination. And then, so you got the imaging app, the cornea app, the cataract app, and then you have the metrics app. The metrics app allows you to measure and quantify these things. You can draw a point here to point here and measure that. That's great for sagittal depth. That's great for patients at risk for narrow angle type issues. A lot of these patients that we see have trauma to the iris. So you can actually make little measurements and determine their risks. And, do they need surgical treatment? Do they need to be monitored more frequently? Patients also can have anterior chamber IOLs in a lot of cases. And so being able to judge distances in those cases just adds to your ability to care for the patient.
So for those in the audience who have not had their hands on a Anterion just yet, walk us through the workflow. So in other words, your technician images an eye, and does the device require additional images to run through different apps, or do I take the same image and process it through different apps?
So each app is a standalone entity. It's almost like its own instrument.
Okay.
And so the first thing that we'll do is we'll do the cornea app, get their topography, their tomography, get the pachymetry. I like to get the epithelial thickness maps, the stromal thickness map. It also has an Ectasia scale that it's sort of kind of like I equate it to like a progression analysis that we'd see when we're using OCT for glaucoma. Kind of helps you monitor if a patient's progressing. So I'll have all of that data, and that's just one scan, same way you would scan like with a topographer. Then they'll click on the next app, which would be, say, the cataract app. That's its own scan, and then but it's just one scan for most of these. The cataract app does have multiple scans because you're getting multiple pieces of data, but it's still pretty quick. Once we capture that, then we'll go to the imaging app. I only order the metrics app if it's a patient that I feel I need to measure something on. So we don't use the metric app routinely like we do the other three apps. Metrics app would be something more like once I see the patient in the exam room, if I feel the need, I need more exact measurements, then I'll send them back.
Yeah, that makes perfect sense. So it's a great time now for us to take a walk through your practice. Please point out things that you find interesting that the audience may find interesting as well. And I'd love to see it myself. So let's take a journey, Randy.
Absolutely.
Great.
Hey everybody, welcome to Family Vision Solutions, a specialty contact lens center. Come on in. This is our reception area. This is where patients come to check in when they arrive for their visit. We have two paths that a patient can take at this office. If we go to the left, that's going to be for doctor visits or anything that's going to the exam room. If the patient is taken to the right, that will be to the contact lens area for dispenses and training classes. Let's go to the left. The first station that they'll stop at is the pre-test station here, where we'll make sure we have all the paperwork ready, and then the pre-tester will take the patient to the pre-test room. This is our pre-test room. Now I'll show you my favorite new toy over here. This is the ANTERION from Heidelberg Engineering. This is a true anterior segment imaging system. It's incredible how much data can be collected in just a short scan. Here we have a typical topography, but I can actually view many aspects of the cornea here. We have our anterior tangential curvature, posterior elevation. We can measure epithelial thickness. We can measure pachymetry, stromal thickness. There's also an Ectasia scale that can be used to help monitor progression of corneal ectasia. These are the apps that the instrument uses. We're on the cornea app now. If we go to the cataract app, this app is used to help calculate IOL implants, but we primarily use it for the biometry, the axial length here at the bottom for our myopia control patients. If we go to the metrics app, this app allows us to draw lines from one point to another and actually get measurements. And then my favorite is the imaging app. The imaging app can take a 16.5 millimeter scan, and it does it in 5 radial patterns. You can even play them and sort of see them go through all 5. So this allows you to see the full fit of a 16.5 millimeter lens, again, in just one scan. So once we're done with pretest, we go over to the exam room, which is right across the hall. This is a typical exam room at this practice. We have anterior segment imaging systems on the slit lamps, but otherwise it's a lot like anyone else's exam room. This is another exam room. And this is our optical. We have a full service optical with a wide selection of different styles. Although we don't do many glasses here, we are full service in what we offer. So now the patient will go along this path, and they'll either check out if everything is finished, or if they have something related to contact lenses, we bring them over to the contact lens area. This is where they'll have education and training. We have our supply closet for contact lenses over here. This is where I keep all the trial lenses. And we also have a edging lab in here. So like I said, full service optical. And then we have our optician's repair shop in here. We also keep our contact lenses that are ready for dispense on the wall here. And then the patients will come back to the front desk to check out and schedule their next appointment.
Wow. I'm really impressed. So given that you created this 40 miles from where you were, now in hindsight, what are some of the things that you are just delighted that you did when outfitting this new practice?
Well, a little bit unrelated, but I'm absolutely delighted that I bought the real estate that I'm in right now.
Okay.
So
makes sense.
If you're a practice owner, I did not understand the value of that until I did it. It's incredible. But from a clinical standpoint, really, I haven't changed a whole lot from what I did when the office was in Houston. We don't really market to patients. We do have our website company, an SEO company. We invest money into that to get patients. So we have started seeing a few of the neighborhood patients, because where we are now, we're less than a mile from my house. I can walk here. I actually did walk here today. This is it's an affluent neighborhood area. There are multiple schools here. There's we're in a complex with an orthodontist and a dentist. And so we get some normal patients that have found us that come in occasionally. So that's kind of interesting. I wouldn't necessarily say it's something that I designed or wanted, but it is good to diversify your patient base, I think. But other than that, really everything that we do here, we did there. I have newer equipment here, but that would have happened had I stayed in Houston as well.
Sure.
There really isn't a whole lot of difference. I do feel like my current office, we utilize the space better. Since we were able to design everything, we set up a flow where the patient just goes in a circle.
Yeah.
And it's more efficient. We don't sell a lot of glasses because most of my patients can't wear glasses. I have an associate who sees some more routine patients that wear glasses, but we set up our office to be sort of a medical clinic. And so when the patient walks in, the waiting area, there's no optical there. It's just a reception desk with a fireplace and the TV. I mean, it's the patient then walks to the pre-test room, then they walk to the exam room, and then as they're walking from the exam room to the front, they pass through the optical, which is in the back. And I find that to be a very efficient flow, especially in those times where you're running behind and you're having patients to wait to dilate and things like that.
Yep.
It just seems a little less hectic in the office.
Yeah, whenever I've asked that question to others, it's the flow that gets the number one response, because you had the opportunity to design it. You weren't trying to put a round peg in a square hole sometimes. You had the opportunity to think it through. What are the steps you want in the patient journey to help them, give them the greatest impression positively, as well as help your staff too?
Right.
So one of the things that we touched on earlier that we're going to focus in on now is trying to limit the refits of a scleral lens when they don't need to be there. So yes, we have complex cases who take more time and take more mental energy, but not talking about that. Talking about the patient who should take this amount of work, but that they don't go off the rails. So when it comes to using the things like the ANTERION to guide lens selection, to look at anatomy, topography, what have you, what are some, because we just discussed the diagnostic data that you're typically acquiring on most of your patients in the order in which you're seeing these patients. What are some things that the Anterion can do for you to guide lens selection without overcomplicating this process?
I believe that everyone should have a sort of a paradigm that's in place that they can fall back to when things don't make sense, when things are not working the way that you expect them to. For me, my paradigm is health, comfort, and vision. My goal is to maximize those three. And I realize I may not get 100% on all three of them, but I want to maximize each of those areas to the fullest. I'm a very skeptical, I guess, person. I do literature review almost every day, at least part of the day, and I doubt everything I read. I look for flaws in the studies. I look for, well, did they consider this? Did they consider that? I truly believe that we're not going to be fitting lenses the same way 100 years from now than we fit them today.
Sure.
And so we don't know everything. Even the studies that show us we know everything, or show us that we know something, that may change in the future. That's how science works. And so I think having a paradigm to help that you can fall back on will help you more efficiently and more quickly come to the decisions that you need to make. And making decisions about fitting, they don't have to be accurate. I've become much more efficient as I've grown in my care, the care that I provide. But in the beginning, I was making mistakes all the time. The difference, I think, is that I made sure that I learned from those mistakes. And so I would make a decision. Okay, I'm going to make the diameter of this larger. And I would do it. And then it would be a disaster. And I'd say, okay, well, learn that lesson. Okay, so let me try something else. As you start doing that more and more, you stop making those mistakes. My next first jump wouldn't necessarily be to go to a larger diameter on that particular problem. But having a paradigm does help you kind of fall back to a solid foundation that allows you to make your decisions. And as you make those decisions, they become more and more accurate as you go. So that being said, I think with the Anterion, lens selection, I think, has more to do with the patient than the testing.
Okay.
Now, there are probably more practices that will jump to a scleral lens as opposed to going to a corneal RGP. But there are some patients I won't fit in a scleral lens, and it's independent of the data I would get from Anterion or anything else. For example, a patient with the kyphoscoliotic form of Ehlers-Danlos syndrome or osteogenesis imperfecta, any kind of collagen disorder that might cause the sclera to be thin and an unstable foundation. They're not going to get options. I have other patients where they get no other options except scleral lenses. A good example of that will be someone with a tube shunt. I will only allow them to have an impression-based lens. If they want something other than that, then they have to go see someone else. I want to try to minimize as best I can the likelihood of tube erosion in those patients. So I think it really is more patient dependent than testing dependent. But where the Anterion does help in that initial lens selection, it definitely helps me decide what to start with. And as far as a trial fitting goes, I still prefer to trial fit patients. I do have a profilometer, and I do order some lenses empirically, like all my bitoric RGPs, I order empirically. My multifocal RGPs that are simultaneous viewing, I order those empirically. But for the most part, I like to trial fit a patient. And the reason is because you get instant feedback on the changes you make. And so while it may be a little more time on the front end, it saves a ton of time in the follow-ups. So when I'm selecting that trial lens, the data that I'm looking for on the Anterion, you can actually see scleral thickness on the Anterion. You can see a global picture of the cornea on Anterion. You can see subtle elevation changes on the anterion. And I'm not just talking at the cornea, I'm talking beyond the cornea. You know, you have that 16.5 millimeter scan. And so I absolutely look at the shape of the eye in front of me to decide what maybe design lens I'm going to use. You know, is it going to be a Boston sight lens? Is it going to be a visionary optics lens? Is it going to be a Blanchard lens? You know, I definitely look at it for that. And then I look at it for, okay, well, how much sagittal depth do I think I'm going to need? You know, based on this data that I have. So it not so much helps me determine what type of lens I'm going to put someone in, but it absolutely helps me narrow down what lens I'm going to start with once I've decided which lens to go with.
So I want to pivot now to long-term success. And so when you have a new patient, a new venture who's not worn a scleral lens in the past, I would presume that patient education is key, because you've already alluded to how much time you spend and your staff spends talking to the patient before you even start to intervene. And then I also want to tie in, you mentioned your paradigm of thinking about health, vision, and comfort. And so in the context of patient education, I really want to get your thoughts. But then also, I'm going to force you to tell me the order of importance of health, vision, and comfort, given that if the patient doesn't end up wearing the lens, even if it's utmost health, it's not doing anybody any good. So I want you to prioritize that, as well as give me some context on things you communicate to the patient that you find the most important.
Sure. So communication is everything. You know, the skill of the person fitting the lens means nothing if you don't meet the patient's expectations. And the only way you're going to meet the expectations of the patient is through education. You know, I see it in all varieties. You know, we'll have patients come in that say, "Oh, my ophthalmologist said you can fix all my problems, so I'm here." You know, or you know, I read online these great Google reviews, and I want to be like that. You know,
right?
Patient education is the key to success. And like I said before, fitting isn't, your skills at fitting are important. Your knowledge of how the eye functions and the pathophysiology in front of you is important. But you will not be a success if the patient doesn't see you as a success. And so in our office, education happens at every interaction with the patient. You know, it starts, like I was saying, with intake, with our staff. It continues during the examination. It continues during the fitting process. It continues at the dispenses. It continues even at the final visit. And a lot of these patients, you know, we're monitoring corneal diseases, so I may see them for a 6-month medical visit to check the progression of keratoconus, or, you know, if they have some risks for transplant rejection. The education happens there too. And so it doesn't take very long for the patients to have that mind shift, to say, okay, I understand this guy's not perfect, but he cares about me and he's going to do the best he can. And it's surprising how many patients are okay with that. You know, they not only okay with that, I mean, grateful for that. I mean, it's really impressive to be able to see day in, day out, grateful patient after grateful patient. And I couldn't imagine practicing any other way. But I know that is not because of my skill. That is 100% because of those little conversations that happen every time we see the patient that reinforce what's real, what, you know, reality. You know, yes, you have this, but, you know, the contact lens can only do this. So we try to normalize imperfection at every visit, because there is no perfection. You know, the lenses fog sometimes. You know, you make sure that it's not, you know, posterior reservoir fogging. You know, maybe it's just fogging from the eye drying out, but then you can treat their dry eye over that and say, well, it's not the lens. You know, the lens doesn't change. The lens is what it is. So you fogging, that's not the lens. that's something with your eye causing the lens
Sure.
to fog. And so we're going to address that too. We're going to treat your dry eye in addition to your keratoconus.
Right.
And so we try to normalize those imperfections, the imperfections of application and removal. People can confuse trouble with putting their lenses on or taking their lenses off with the fit of the lens not being correct. And how would they know otherwise if you don't educate them on that? So we give them permission to make mistakes. We give them permission to mess up, permission to take 30 minutes to put their lenses on. And
right.
It's amazing how much it helps. It just shifts the mindset. With health, comfort, and vision, I mean, I would like to say they're all equally important. I
I
think
know.
academically they are.
That's why I was
Yeah,
forcing
but
you, Randy, to prioritize.
yeah, but I definitely get what you're saying. We don't get them all equal. And my conversations with the patient, because I tell them what my paradigm is, my conversations with the patient are kind of along the lines of, I want to make sure that I give a lens that doesn't cause any long-term problems for you. That's going to take me a while to do, because I'm also trying to balance out your vision and your comfort.
Mm-hmm.
And so don't be surprised if the first couple of lenses don't feel all that great. Don't be surprised if the vision with the first lens or two isn't what you want it to be. This is a process, and it's a process where I'm just maximizing each area, because sometimes when I give in one area, it takes from another. And we will achieve a good balance, but it takes time. And my priority, I do have patients where this could be a whole new lecture or presentation, but limbal clearance, for example.
Mm-hmm.
So there are no studies that definitively prove X amount of compression at the limbus causes limbal stem cell deficiency or problems with that area. We have observations. We have observations that when this, then that happens. And so we've set the rule of, never touch the limbus, never touch the limbal area with the lens. That's not always realistic in some of these patients. The majority of lens designs are concentric. The limbus isn't necessarily concentric.
Right.
We call the limbal area, right here, where this is where the limbus is. But we don't really know that's exactly where it demarcates. We know that the conjunctival epithelium and the vascularization start to end. Bowman's begins and the corneal epithelium begins, and then it becomes non-vascular. And it's in that transition zone where the limbus is. These limbal stem cells are deep within the palisades. Touching that area lightly, does that root truly have an impact? I don't think we're going to know that for a while.
Right. You're probably right.
And so I may, and I do have several patients where I may accept, for example, a little inferior temporal decentration, because the only way for me to get rid of that would maybe go to a molded lens that the patient can't afford. So I may accept that, but just follow up with them more frequently and stain the cornea to see if, there's something there. So that occasionally I do sacrifice health in that regard, but anytime I do, it's potential health problems that I'm sacrificing, not definitive health problems. And I'm following up with the patient on a more frequent schedule just to make sure that I'm not causing any problems. Comfort, I think, is key. You have to have comfort at least 95%, because you're right, they won't wear it. I have a few patients who, as we would go through the fitting process, they would wear these uncomfortable lenses because they needed to function.
Yeah.
But you don't want that. And right. So I do try to get comfort as high as I possibly can 100% of the time.
Yep.
And vision, I think, is probably what I would sacrifice on the most.
Sure.
Vision, I kind of look at it as like cataract surgery. A patient goes in for cataract surgery, even with the premium implants, you don't know if that implant's going to fix all of the problems. You know, you don't know if that implant is going to fix their expectations.
Sure.
And so, you know, the vision with these contact lenses is, I view it sort of the same way. I have patients in scleral lenses that I don't want to put front toric power on. In fact, as a general rule, I don't like to do that. I feel that it adds complexity to the fit. It drags
Sure
out
it
the
does.
fitting process.
Mm-hmm.
It's less forgiving if the patient puts the lens on not at the perfect angle.
Mm-hmm.
And so if I can avoid that, I will. And so I have some patients where if they do have true internal astigmatism along with their corneal astigmatism, I may give them a glasses prescription to wear on top.
Sure.
You know, the research, we know that internal astigmatism is real. You know, we know that it exists, but it's not common. You know, the bulk of the astigmatism is at the cornea. And what I've found over the years is that when you have a cylinder over refraction, a lot of the time it's because of how you fit that lens. You know, a general statement, and this is an oversimplification, but would be if you fit a lens with too much sagittal depth. When I first started doing this back in 2008, working with scleral lenses, the thought was you need to have at least 250 microns of clearance. The lens thickness in my fitting sets, I'll never forget this, they were 500 microns thick. Those were my trial lenses. And because that was the standard thickness that they would order, or that the labs would make. And so in a case like that, I didn't really see a whole lot of residual astigmatism because that lens was so thick,
Right.
you
Mm-hmm.
know. When we started going down to 200 micron thick lenses, even in my exam rooms, I started seeing more and more cylinder over refractions. And so, you know, I'll do things like thicken the lens sometimes. You know, I'm a firm believer in the research of, you know, that post lens fluid reservoir has more impact than the thickness of the lens does. And so if I can correct a diopter and a quarter of astigmatism by going to a 0.35 thickness,
Mm-hmm.
you know, I'll do that. And if I think it's a threat to the patient, then maybe I'll follow up with them on closer intervals. You know, just again, balancing the health, comfort, and vision the best I can.
All right, so where I want to wrap this up and kind of come full circle, I'm going to lead into one of the things that you just said in passing that I absolutely loved. And that is, I think, incredibly impactful take home for all ECPs, but especially newer ones. And that is giving them permission not to be perfect and not to seek perfection. Because first off, even what we consider a healthy, normal patient is not perfect by any means. And so do not limit yourself or retard your progression or your successes because you're looking for perfect, because you may get disheartened for something that you're just shooting for the moon. So here's the stage. You're Randy, you're at GSLS and you're moderating a roundtable. So I set that up purposefully because the attendees at your roundtable, they're new ECPs, but they wouldn't be there if they didn't have an interest in this whole area of scleral and complicated contact lens fitting. And your goal is to break it all down to one or two take homes for them to push them forward, relieve some barriers, you know, push their motivation, don't make them scared. Is it as simple as don't go for perfection, or there's some other tidbits that you can give this group of excited, you know, young ECPs who want to be on your eventual journey but just need a little shove?
So the first is probably the most important, which is failure is the best teacher. I know that people who achieve the level of obtaining a doctorate are often the people who push themselves, who failure makes them uncomfortable.
True.
But the fact is that failure is the best teacher, especially when we are practicing in a world where we don't know all the rules. And in order to come up with systems that work consistently, they won't work every time. I have no system in my office that works 100% of the time. But to come up with systems that work most of the time, those come from failures. And so I wouldn't say necessarily don't be afraid to fail. I would say try to fail. Make decisions and see what the outcome is. You know, that is what's going to teach you. And these failures won't last long. You know, I think the bulk of my failures were in my first 2 years of practice. And while I still have failures now, they're less frequent. So I think that is the by far the most important thing. But also rely on your systems that you set up. You know, if you have a paradigm in place, whatever it is, health, comfort, and vision, you know, taking care of the patient, whatever it is, when you set up your systems at each level of the patient's journey, make decisions on exactly how you want it to go. Because if you don't, you're just leaving it up to chance. You're leaving it up to how your technician feels that day, you know, or you know, what kind of morning the receptionist had when the patient called, you know. But if you have these clear expectations, you know, there's a great book called The Checklist Manifesto. I forget who wrote it, but basically it's a surgeon who he started using checklists in a hospital system.
Okay.
And what he found was that even professionals, even the surgeons themselves,
Right.
made errors consistently when they relied on memory and routine. When those checklists were implemented, the error rate dropped dramatically in multiple areas of the hospital. We're relying on our staff to make decisions when they're interacting with patients. You know, we're relying on them to do what we would do as practice owners. That's not always a good, or that's never a good idea. You know, having a checklist of when you interacted with this patient at this level of their journey, did you do this, 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 and this? You know, that will keep things consistent. That will build confidence with the patient. You know, they will see the purpose in every step of the journey. So I think focusing on your systems is critical when it comes to long-term practice success, because if you don't, like I said, you're just relying on chance.
Totally. I love it. Well, you know, I can't say thank you enough, Dr. Charrier, for sharing your expertise, your advice, your insights, your journey in eye care, as well as your practice. It's been enlightening. You know, I've loved every minute of this discussion, and I would say wholeheartedly, I'd love to have you on a future episode, because this has been a wonderful conversation. Thank you, and thank to everybody in attendance.
Hey,
Yes.
family, if you enjoyed this full podcast, don't miss out on more engaging content. Check out the next episode right here. And for the latest updates, hit that subscribe button and ring the notification bell. Your support means the world to us. Catch us in the next episode. Peace.